Welcome to the Biotech and MedTech panel. My name is Radu. I'm doing a PhD in medical research, and I'm also QTech CFO. We have a very exciting group of panelists today, and I'll jump right in and briefly introduce them. I would like to welcome Mike Capaldi, the head of Edinburgh BioQuarter, James Balmain, the founder and CEO of Zesty, and Inga Deakin from Imperial Innovation. After their free talks, we would open the panel for discussion and Q&A. Our first speaker, Mike Capaldi, has over 30 years experience in the pharma industry in the UK, Europe, and the US. In his early career, he has worked for large companies like GSK and Amersham, and for the last 18 years, Mike has been the executive director on the boards of an impressive list of companies. Currently, he's the non-executive director of StealthX Therapeutics, Roslin Cells, and Synaptica. Mike has extensive experience in raising capital, having helped raise over 80 million for a number of companies in the past 20 years. He has also extensive experience with mergers and acquisitions, and on top of that, sits on various regional and national advisory boards, including the Secretary of State for Scotland's Business Advisory Board. Without further ado, I'll hand over to Mike so he can tell us about the innovations that will bring about the healthcare of the future.
Thank you. Well, actually, I'm delighted to be here. This is a great meeting, and you guys have done a great job in pulling together some really good panels and some good discussions. So the question here today is modern healthcare, can we afford it? And that's a really thorny issue, so let's get straight into it. And there are many considerations that need to be taken on board before we can decide whether we can afford modern healthcare. We all know that the population is aging rapidly. This is going to have a significant effect. As you get older, you get iller. So prepare yourselves, and let's talk a little bit about how that's going to affect things. Genomics. We now have the ability to look deeply inside individuals' genomes and start to understand disease at a much more biological level on an individual to individual basis. And actually what that tells us is that we need to be much cleverer and much smarter about the ways we're developing drugs for the future. That's going to be more expensive. Medical technology, you only need to walk into a hospital 50 years ago and compare the sorts of equipment and drugs that you saw and compare with what you'll see today to know that medical technology has just absolutely boomed in the last 15 years, but it's all much more expensive and much more sophisticated. The regulators obviously have a say in all of this, and we always hear in the news, NICE has allowed this or has disallowed that, and everyone gets very upset about it. But there's only a limited amount of money at the moment, and sometimes you have to make hard decisions, so we'll look a little bit about that as well. And then there's personal expectations, of course. Everyone, if they've got a close member of their family who's diagnosed with a serious disease, suddenly cost goes out the window. It doesn't matter. I want the best possible treatment for my mother or for my grandmother or whatever. But the question is, actually, can we afford that? So let's go through each of those and just unpick them a bit and look at some of the challenges. So the aging population, which obviously doesn't want to, is that me? Or there we go. Thank you. So here we have the rise of man. And you see the population has been fairly consistent for a long time. And it's only within about the last 200-300 years that the population has exploded. And they reckon it's going to equilibrate somewhere around 10 billion people. But that's going to cause a problem. And most of this, of course, has happened in the last 100 years. And one of the things that's changing is that we're living longer, so it's changing the dynamic of the population that we live in. So if you look in the 1950s, only about 5% of the population was made up of 65-plus-year-olds. By 2050, that'll be about 16 or 17% of the population. And once you get to 65, it's that sort of magic age where things start to fall off and things start to go downhill. And we all need more medication. We all need more looking after. But actually, we're also going to see a significant increase in the very old people as well. And these are people that do need a lot of care. I mean, you're very lucky if you're 100+ years old and still playing tennis. Most of us won't be if we actually get that far. I don't know whether I'm not pressing this hard enough or whether the batteries are running out or something. There we go. So here we have some statistics from the Office for National Statistics. You can read it for yourself, but basically, you know, babies born now are expected to survive to celebrate their 100th birthday, about 1/3 of those. About 95,000 people aged 65 in 2012 are expected to celebrate their 100th birthday. I'm not sure if that's a good thing or a bad thing. The total number of centenarians is projected to rise from 14,500 in 2012 to about 110,000 in 2035. So just some statistics there to set the scene, but this is going to be an interesting problem. And the problem is that we know a lot of diseases are age-related. So cancer is a classic example of that, that as you get older, you've got a much, much higher chance of getting cancer. So if you look at the top line, the blue line there, that's the rate of cancer against age in men. And actually, women are higher in the early years, but men start to take them over in the later years, unfortunately. And then the bars represent the number of cases of cancer. And you can see at the moment they peak about the mid-70s, the high 70s. But that's because, of course, people are dying from those diseases. As we start to cure those diseases and they start to get other diseases as well, those bars will just increase. So we're going to see more and more and more cancer in our population. It's just a fact of life. And in fact, I read a statistic somewhere that about 1 in 2 of us will get cancer at some stage in our life moving forwards because we're living longer. And actually what that means, therefore, is that the cost per capita of providing health care to a nation gets higher and higher and higher against age. Now, if you look in the States, obviously it's a different system there. It's private healthcare, and you know, in terms of diagnostic procedures, they tend to throw absolutely everything at you, and it's very expensive. But even in Europe, it's about 4 times as expensive to treat somebody in their 70s and their 80s as it is to treat somebody who's 10 years old. So we know that as the population grows and gets older, the expense bill is going to rise. And actually, what that means is that if you look at the spending since 1980 through to 2010 per country, it's rocketing. And it's gone up by about 5 or 6 times. Now, if you compare that with the rate of inflation, so £100 in 1980 is probably worth somewhere in the region of £300 now. So the cost of providing healthcare is running ahead of inflation. So it's increasingly becoming more and more and more expensive. Clearly, that's not sustainable. So, now that we've scared ourselves to death about thank you. Now that we've scared ourselves to death about genomics, I'll just ask for the next slide as we move ahead. Could we have the next slide, please? No? Yes?
I think you need to just press it much harder.
Okay, I'll put it on the ground and jump on it, maybe. So the sequencing explosion, and it is an explosion. So we can now sequence the human genomes. Some of you will remember Bill Clinton and Tony Blair standing up 15 years ago and saying, we're going to sequence the human genome, and that's going to revolutionize medicine. And they were right, it is. It's taken a little bit longer than we thought, but it is revolutionizing medicine. Back in 2000, before 2000, it cost about $3 billion to sequence one human genome and took many years. Now we can do it for less than $2,000, and in a year or 2 time it's going to be $1,000. You're going to be able to get this done online. You're going to be able to take a drop of blood, send it in, and get your gene sequence back the following day by return of post. And obviously the number of genomes that have been sequenced is now growing exponentially. That's a log scale on the right-hand side. And the reason why this is important is because we're now learning things that we didn't hitherto realize. And that is the one thing actually that we always knew, which is we're all different. But what the implications of this is that actually one drug doesn't work for everyone. And we now need to start treating people on an individual basis, because what you give to one person isn't going to work for another person, because biologically we are all different. So for example, if you look at antidepressant drugs, take people who are depressed and treat them, a drug on average is only going to work on 62% of those people. And if you get down to something like cancer, when you give somebody an anti-cancer drug, it's only going to work about 1/4 of the time. Which is not good, because it means that 3/4 of the people are being given a drug that's incredibly toxic, that's making them very sick, but actually is doing absolutely nothing for their cancer. But actually, more importantly, it's a waste of money. So in 75% of the cases, the drugs that you're giving, it's just a waste of money because it's not going to do anything. I'm moving over to 2 fingers now to press on this button. So here's a population of people, and the quadrant, and you can sort of look at them in 4 ways. The quadrant that you want to be in is your lower right-hand side, where the drug is beneficial, it works, and it's not toxic. So the drug's working, it's curing your disease, and it's not giving you side effects. The worst place to be is one above that. The drug is toxic, so it's making you feel awful, and it's not doing you any good. And that's a waste of money as well. And then as we move around the clock, in an anti-clockwise, the drug is toxic but beneficial, or the drug is not toxic but not beneficial. And you're going to get all those, and actually what we need to do, of course, is for each one of those people, they're probably going to require a different approach. But as you can imagine, that's going to get increasingly expensive. Hitherto, what we used to do was develop a drug for cancer and give it to everyone and hope that everyone was going to get better. We now know that that doesn't work. We wasted an awful lot of money in doing that, and a lot of people didn't get better. So we need to get much smarter in the way we're actually doing things and delivering medication. Okay, so we're now on medical technology, and I just want to spend a little bit of time talking about drug development, because we're sort of majoring on the drug theme here, but obviously there are other parts of technology that are increasingly cost as well, and some of you will know this and some of you won't. So this is the drug discovery and development process. If you look along the bottom, it takes about 15 years, and it goes through various phases. But the one thing I want you to notice is that for every drug that gets to the market, the number 1 on the right-hand side, you have to start with about 10,000 different compounds. And there's a huge attrition rate, and the attrition rate is because, a lot of the drugs that you're developing, they don't work, they're not efficacious, or they're too toxic, or you can't formulate them in the right way, or they're too expensive to manufacture, loads and loads of reasons. But the point is that you'd have to spend loads of money up front, and then when you get into clinical trials, they're very expensive as well. And when you add that all together, the cost of developing a successful drug also has to be, you have to take into consideration what was the cost of all the wasted research you did as well. And if you do all that, it's over $1 billion per drug that gets onto the market. So think what I've just said. We've now got to develop lots more drugs because we've got to treat lots of different people in different ways because of personalized medicine and what we're working towards. But it costs an absolute fortune to develop a drug, so how on earth are we going to be able to afford to do all of that? And one of the other challenges we've got is that, so the squiggly line that's going up and down is the number of new drugs that have come onto the market since the 1970s. And what you'll notice, apart from a bit of a spike in the mid-90s when we thought we cracked it with high-throughput screening, but it was relatively short-lived, that the number of new drugs coming to market hasn't really changed. But what you'll notice is the red line is the cost of developing those new drugs, and that cost is going through the roof, but the number of drugs coming through is still the same. And yet what we need is probably 3 or 4 times as many drugs as we get into personalized medicine, and that cost is just going to keep going higher and higher. So it doesn't take a mathematician to work out that this is very, very rapidly becoming unsustainable in terms of what we currently do. Go. And there are lots of new drugs in the pipeline. So down the left-hand side is various biologic drugs. So the biologic drugs are the latest hot thing. These aren't small chemical entities. They're sort of biological molecules. They tend to be very powerful, and they have been incredibly effective for treating some diseases. But they are very expensive. Lots of drugs in the pipeline. But look at the cost of some of these drugs coming to market now. So $575,000 per year to treat Pompei's disease. Psoriasis, $486,000 per year. Again, you don't need to be a mathematician to know that this is not sustainable. And this headline appeared on the internet in November 2014. Glybera, some of you will have heard of that, the world's most expensive drug with a price tag of $1.4 million US. It was the world's first gene editing drug, very, very successful. But if you read down towards the bottom, there's only going to be about 150 to 200 people that are going to be appropriate for that drug, that have that disease. So it's an incredibly expensive drug, but on the other hand, it cures a disease which was hitherto incurable. So you kind of have to weigh up the cost of administering that drug against the cost of what it might have cost you had they not had access to that drug and they'd continued to be ill with the disease for the next 10 or 15 years before they subsequently died. And those are some of the decisions that NICE are having to make moving forward. So let's get into the regulators, because it's the regulators that are going to decide some of this stuff moving forward. And so here's an interesting one, and I think this took a lot of people by surprise. So here's a drug, eculizumab, for treating PNH, which was effectively a disease that people, it was incurable. People had to live with this terrible disease for a long time. It costs per year for treating in the UK £340,000 every year, but it cures the disease, and it'll keep the people alive for the next 25 years, and over the course of their life, it will cost about £100 million per patient. But NICE actually sat down and did the back of the envelope calculation, or maybe they put a little bit more work into it than that, and actually said, no, actually we're going to prescribe this drug because it's going to save us money in the long run. I think that's a very interesting decision. It's a very bold decision, but that's why you have to weigh out both sides of the equation. It is incredibly expensive, but there is a sting in the tail, if I could get this thing to move forward, and that is that this group from York University sat down and did some maths. So when you look at the benefit that people get from drugs, regulators talk about quality-adjusted life years. And that basically means, how much better do I feel over the course of the next year? And it's a measurement. It's done by asking various questions and things. And what NICE have been working on is a figure of somewhere between £20,000 and £30,000. So it's worth treating somebody if you get one quality-adjusted life year for £20,000 or £30,000. In fact, this group at York said, no, that's too high. It's £18,000. But effectively, what we're saying is that if you spend more than £18,000 on getting one quality-adjusted life year for a patient, you're actually taking something away from somebody else on the NHS that would have got more benefit. So £18,000 is about the amount you can spend. If you're spending more than that on a quality-adjusted life year, you're wasting money because you're actually taking it away from somebody else in the healthcare system that could have benefited more. And of course, it's not just drugs that are very important. It's lots of other technologies. 50 years ago, you went to visit your GP. Cost of visiting a GP now is about £45. Maybe 30 years ago, you'd have been sent for chest X-ray if you had some sort of problem. They wanted to know what was going on. Now you go for an MRI scan or a CT scan or a PET scan. And again, medical technology, it's just become incredibly expensive. But these are all routine things that patients are subjected to all the time. So everywhere in medicine is just getting much more expensive. So just to finish off, let's quickly look at personal expectations. Shakespeare said expectation is the root of all heartache. Absolutely right. We've all got expectations. We've all got reality. And there's a big problem between the two things. And here's one of the problems. One of the problems in the UK is that we just expect that this stuff's going to happen, but we bitch and moan when taxes go up to pay for it. But actually, at the end of the day, look at the percentage of GDP in the States they spend on healthcare. And we're right down the bottom of the league tables in Europe in terms of the amount of money we spend on healthcare moving forwards. So that has to change. If we want to hire our expectations in terms of the care that we expect to receive from the health system, we're going to have to pay for it, basically. And of course, it's not just the cost of drugs, it's the cost of anything. Running our hospitals, dentistry, care in the community, even bigger than the prescribing bill, mental health, a massive pull and resource. So these are huge figures, and all of these are growing in terms of complexity and in terms of expenses moving forward. So, to answer the question, can we afford it? Without changes, absolutely not. There is no way that this is sustainable. We cannot go on the way we're doing at the moment. But there are lots of things we can do here. Preventative measures, and that's already been mentioned today. Vaccination. Let's stop people getting ill before they're actually ill. Precision medicine. I talked about needing more drugs and the higher cost of those drugs. But what it means at least is that you're treating the right people with the right drug, and you're not wasting 75% of what you're administering to people giving drugs that aren't going to work and never were going to work in the first place. So we have to get smarter about doing that. And then things like digital health, and we're going to hear a little bit about that. But digital health, it's really expensive to bring people into hospital. Wouldn't it be better, if they don't need to be in hospital, to have them at home, remotely monitor them, and then bring them in when there's some sort of medical crisis and they need to be in? So lots of things we can do, but we have to significantly change the way we're doing things at the moment. Thank you.
Thank you very much, Mike.